cells, and we dye them with their antigen, the antibodies, just to make sure we can see that initial mutation. We typically did surface markers, and we did intracellular arginase 1 because that is the I guess protein that we're analyzing. And then we have flow cytometry, or if you're actually referring to it. This just kind of highlights the dyes we already done in the previous step. And then we have gating. Gating is where you see that you can see the cell population. So you'll typically have one large cell population, and then you go into single cell, living, immune, etc. And then the next one, we have arginase 1 expression, what we're actually focusing on within these myeloid cell subtypes. And here we have our summary. So we have the M1, M2, MDSCs, PMMDSCs. We have you can see in tumor, it was more expressed high for all 4 of those. And then blood, we saw moderate within the first 3, but within the PMMDSCs, it was relatively low in comparison to the other ones. And for arginase 1, this is our data just roughly. You can kind of see what I stated before. The PMDSCs, the myeloid cell subtype is significantly low in the blood in comparison to the tumor, whereas M1 and M2 MMDSCs, those are relatively about the same. And there's the P, if you want to see the p-value is the component of this chart. And I think for future plans, we are actually planning, once we can kind of see, or if we can kind of see, hopefully, that one of these myeloid cell subtypes actually does express arginase 1, or maybe expresses it even lower than the others. We take the one that expressed the highest, and we take the one that expressed the lowest. And we combine that with the T cell. It's actually called co-cultural. So you can see in the diagram, we have the myeloid cell co-cultural with the high arginase 1 expression. Then you can see that hopefully, we can see that the suppressed T cells actually are suppressed rather than in theory it can actually be proven. And then the other one below that, that's actually showing the low arginase, and it shows the myeloid cell that was showing the least. And just as a reminder, the subtypes were myeloid cell 1, macrophage 1, macrophage 2, PMMDSCs, and MMDSCs. And that was our future plans, and these are my citations. I want to go back in the slide just to make sure we didn't skip anything. And okay, just making sure. But yes, that is the rest of my presentation, and I hope you enjoyed it.
Amazing job. That was outstanding. Okay, we have time for a question or two. Anyone have any questions? And online, if you have a question, then you are welcome to ask it. Is that your family?
One of our mentors there.
Is that your family? We can't hear him this year. Does anyone have a question?
It says non-human.
It says what?
Non-human.
She's managing it. Yeah.
What's the most challenging?
Any questions?
No question. I'm open to questions.
Are there any on the Zoom?
Yeah. Well, what was your favorite part that you learned? What did you really enjoy learning about this type of cancer? Oh, as far as my favorite part, I think it was learning the intricacies of the myeloid cells. It was a very difficult thing, but often nothing is worth doing. It's not difficult. So I enjoyed that. I also enjoyed learning about T cells and how they function or how they are impaired, typically by the arginase 1 expression. And I don't know if I specified, but amino acids or the enzyme for arginine, that's actually an amino acid, and arginase is an enzyme that breaks that down. So in case I didn't clarify that before, this is my favorite part.
I have a question for you. So often there are lots of different cancers that the immune system will play a role in either how they develop or how we're able to treat them.
Yes.
As you learned about the impact of these myeloid cells and macrophages and T cells, when you think about how this could impact patients with neuroblastoma, what do you see as the future of this potentially being harnessed or used to treat patients?
For this specific study, I do not want to do my own conjectures because I am an intern that's expressing this. But I want to say ideally, maybe we can identify a drug that's already on the market and test that with the T cells to see possibly does that affect or possibly block the arginase expression or even remove that myeloid cell subtype completely.
That's a perfect answer because that is a lot of what we're trying to do is see if we can block some of these cells, and then be able to harness the T cells so that these cells don't block the ability of them to work. So outstanding job. Yay. Okay, we'll do one more.
From Janelle, it said, what was the most challenging part in your research?
Oh, that's a fun question.
30 seconds.
Honestly, it was getting this on a slide that was simple enough to explain. It was very intricate. It was very in-depth explanations that I wanted to provide. However, I did not simplify it.
Yes.
So if you have questions after this, I'm going to answer them.
And you did an outstanding job simplifying. That's one of the hardest parts of science, is trying to whittle it down to a presentation that's very short. Thank you so much. And next we actually have JC, who is joining us online. JC, are you ready? I'm gonna advance your slides for you.
Okay, thank you.
All right. Okay, here's a little background about JC. JC got to work with Dr. Erin Thrift on epidemiology and population, and she was very interested in looking at liver cancer, specifically in African Americans, which very closely aligned with her work. And she wants to be an anesthesiologist, but we'll convince her to be an oncologist. All right, JC, take it away.
Hi, everybody. My name is JC
You're
Tojo.
muted, or we can't hear you. Is it?
Can you hear me now?
1 second, JC.
Okay.
Okay, try again.
Hello.
I can hear. It sounds fine.
Okay, try one more time.
Hi.
Have time, if we come back to you, we're gonna have our tech person try to troubleshoot.
Okay.
Is that okay?
Yes.
I think we'll go to the next presenter, and then I'll let him know what the issue is, and we'll
Okay.
see if we can troubleshoot it. Okay, JC?
Okay.
All right, thank you. Sorry for the false start. Oh. So we had someone who was gonna present on Zoom, and they can hear on the Zoom, but we can't hear it here. But I was gonna come fix it. Right now, I just want to advance to the next one. I advanced it on here, but it didn't. And then on here, it's advancing, it's like that. I mean, I was doing it in the presentation. Oh, on there. So I just go to that one. Let's see. Okay, it was working. Okay. Okay. And then do you know it will be able to hear that? I should be able to. Okay, I'm gonna have her present, and then we'll get our apparatus. All right, awesome. Okay, can y'all hear me okay on Zoom? Yeah, all right. Well, next we have Samaya, and she worked with Dr. Sharma, who's a rad onc doctor, and I'm excited to see this presentation. She wants to be an orthopedic physician, but also is very interested in community engagement. So we are excited to hear you present. Yeah.
Okay. Good morning, everyone. As Dr. Rouse said, my name is Samaya Hughes, and I work with Dr. Shelly Sharma over this summer. She's an accomplished radiation oncologist who specializes in sarcomas, carcinomas, breast and gynecology brachytherapy. So I work on the planning phase of the Care Connect Quality Improvement Initiative. Care Connect is attempting to create a educational series and cancer support group for patients at the Dan L. Duncan Cancer Center to improve and enhance patient-centered care as well as patient satisfaction. So modern day cancer treatment is a multidisciplinary care. When patients come in to get treated for their disease, they are typically going to first see a surgical oncologist to remove their physical lesions, then a medical oncologist to administer immuno and chemotherapy, and finally a radiation oncologist to then remove or shrink any excess cancer DNA. Now, these are the main three modalities. However, in cancer treatment, due to the immense physical and psychological stress a patient goes through after diagnosis and treatment, there are many other symptoms and underlying signs and concerns that patients may have with their treatment. For example, it takes a large toll on your appetite when you're going through radiation therapy, so patients may eat less and lose weight. That's not a great sign, as you need to be a healthy weight so that your treatment can be most effective. So as a result, they may need to see a nutritionist. Now,
My niece,
when a
my
patient
niece is in the
comes
medical
the
cancer
first
research
1 hour
program
consult
because
at the
she's applying
radiation
for medical
clinic,
school next year.
doctors are
And she's doing her
going
presentation
to
at
see
10:20
them
today.
and barely
And
have
you
the
get to just
time
dial
to
into the
address their
Zoom
individual
in.
concerns
When she
as
comes
they
up, I'll let
must
you know. It's
first
another girl
discuss
on.
and stress
I am
what
so
type of
proud. I
treatment
am
they're
so proud.
receiving so that the patient may understand it. So during that hour, the patient has to first complete
They are
onboarding.
just like, they are off. I mean, they know
Miss
what they
Tasha,
want to
can you
do.
mute
They
Then
going
please?
doctors
hard. They
must
Miss
compete
Tasha,
like
review
hello?
imaging and
with their
history
friends,
all before
with their
they see that
GPAs
patient.
and stuff. And I'm
Now,
like,
this
they have a
means
friend that
that
has a
when they are
4.8
discussing
GPA.
their treatment, they are
And they're
again
all, yeah, and
unable
they're
to
all
address
like,
those concerns
and
and
they're all
other
like,
potential
we are coming for her.
symptoms.
We are
It's
coming for her.
unrealistic to send
But
patients to these other modalities every single time a patient has a concern as well. Dr. Sharma noticed this deficit, and it was my job to prospectively assess the needs of our patients at the Dan L. Duncan Cancer Center so that we can then implement their preferred methods of meetings, main concerns, as well as meeting times into our future cancer support group. Now, the methodology used for this were these questionnaires that Dr. Sharma produced, and I was to give out these questionnaires to various patients on the breast, gynecology, and radiation clinics at the Oak Quinn Towers. There were 10 questions, one being an open-ended questionnaire, and it was anonymously filled out by voluntary patients over a 2-week period. They were given both on paper and electronically through QR codes over those 2 weeks. Now, moving on to the results, after 100 questionnaires were collected, I went ahead and analyzed the data. For our treatment cycle, we can see that 51% of our patients were still completing their radiation therapy, while 44% of the patients were there for follow-ups. The patients had about 87% of the population being guardians to children that are under the age of 10. Then, for their age range, most of the patients, 97% of that population, were over the age of 40. And finally, 57% of our population were still working either part-time or full-time jobs. 87% of the population was English speakers, and the last 13% were Spanish speakers. Starting with the patient's concerns, we can see that on the top, Spanish-speaking populations advocated primarily for knowledge on fatigue, anxiety, work treatment balance, nutrition, and side effects of their radiation treatment. While patients that were of the English-speaking population advocated primarily for side effects, anxiety, nutrition, fatigue, and work treatment balance information. So we can see that while both populations advocated for the similar first 5 topics, their priorities were a bit different. And looking over to the right, you can see the entire population's requested support type. The green showing that majority of the patients would prefer a combination of peer support, the education series, and one-on-one counseling. Okay. Now moving on to the time and format. On the left-hand side, you can see that primarily patients wanted their meetings to be before or during their clinic visit or Monday through Friday after 5 p.m. This makes sense. As we saw before, most of the patient population is in the working class and may not be able to make these other appointment times. And on the right, you can see that they would all prefer, or majority of the population would prefer, virtual meetings, as 42% stated that they would like a virtual meeting, and this is about half of the population that stated that they would participate in our educational series or cancer support group. Now, how will we move forward with this intervention? So to implement this into our cancer center, we have decided that the meeting times will be after 5 p.m. throughout the work week for an hour. The hour will be broken up into 30-minute sessions, one being an educational session and the other being patient interaction activities to address the combination that the entire population wanted. Now, as for the meeting intervals, they'll occur monthly, and as only 22% of the population wanted in-person meetings, we're only going to have in-person cancer patient support groups occur quarterly throughout the year. And finally, we'll be first addressing anxiety, side effect, and fatigue as our first meeting topics, since they were prioritized the most throughout this survey. Other takeaways from this experience are just being in the medical field. This was my first ever research experience, so I was very excited. And working with Dr. Shirley Sharma was amazing. Like, every single part of her lab was intriguing. I was able to talk one-on-one with patients and hear their stories, understand where they were coming from, and how all of that intersected with the data that we collected. It was very interesting. But thank you, Dr. Sharma and the P20 CURED team for having me. And this is a great experience. Thank you.
Outstanding job. Any questions yet? I have one while we wait. Are they online? Check. Anybody in here have a question? Okay, one question. So this is outstanding.
Yeah.
I think one question that I have for you is I think you really noted the multidisciplinary nature and how limited the time with the provider is, but then also these additional needs of nutrition and maybe some social work needs, et cetera, financial needs. Do you intend that you have other professionals join these support groups, like a nutritionist, perhaps like a social worker?
Yes. So going forward, we've already met and discussed this data already with other doctors and physicians. We have a volunteer team of over 20 individuals, including myself, who are willing to come out and provide expert opinions on and medical advice through these sessions. For example, Dr. Lahardy, she is a nutritionist that works at the Oakland Tower Clinic, and she is an amazing physician. She's already created graphics that will be handing out with those. So On top of that, we also stated that there was a lot of patients that were interested in learning how to balance work and their treatments, as treatments take time out of the week where they have to take off work, use their PTO. So yes, a social worker will also be involved to kind of help alleviate these challenges and hopefully find some type of medium where they're not solely depending on themselves versus the
Awesome. And last question, I assume you plan to have Spanish speaking
Yes.
groups as well.
I completely forgot to mention, but there will be Spanish transcripts offered with these first few educational sessions. And then as we plan to increase the intervals of these meetings, hopefully to 2 to 4 times a month, those Spanish speaking groups will have their own separate sessions.
Amazing, thank you. Okay, we're going to do Miss Talaya next. And Talaya is a P1 pharmacy student interested in breast cancer.
P2 now.
Help, oh, P2
P2
now,
now.
excuse me, here, come over here, because you'll be using this. It's okay. So they can, oh, you can actually stand there. You can go stand there. And she wants to combine research and clinical practice to advance cancer treatment. So we will definitely try to keep her in the cancer research family. Without further ado, oh, okay. Go ahead. This one goes forward, this one backward.
Okay. Good morning, my name is Talaya, and this summer I had the opportunity to work alongside Hilda and Zaid under Dr. Eric Chang. And today I'll be presenting our project evaluating Wnt5 protein expression in cell line models. The overall goal of this project was to investigate proteins involved in the Wnt signaling pathway that may play a role in communication between breast cancer cells and surrounding cells in the tumor microenvironment. To begin, breast cancer remains one of the most significant health challenges worldwide. Traditionally, we think of cancer as being made of only cancer cells, but tumors are actually much more complex than that. Cancer cells exist within what is called the tumor microenvironment. The tumor microenvironment includes many normal non-cancerous cells that surround the tumor, such as blood vessels, immune cells, fibroblasts, and parasites. Rather than simply existing next to the tumor, these surrounding cells constantly communicate with cancer cells. This communication influences how the tumor grows, survives, and eventually spreads. Because of this, researchers have become increasingly interested in understanding not only the cancer cells themselves, but also how the surrounding cells contribute to disease progression. This slide highlights the characteristics of cancer progression. First, the cancer cells are uncontrolled, meaning they continue dividing without responding to the normal signals. That's not helping growing. Then second, cancer cells participate in intercellular signaling. They constantly send and receive signals with neighboring cells. These signals help the tumor survive. And finally, the cancer cells are capable of tissue invasion. As the disease progresses, malignant cells invade nearby healthy tissues and may eventually enter the bloodstream and lymphatic system, allowing them to spread to other parts of the body. One of the surrounding cell types involved in this communication is the parasite, which became the focus of our research. And then the parasites are that normally wrap around small blood vessels. Under healthy conditions, they help maintain blood vessel stability and regulate blood flow. However, within the tumors, their behavior can change. Instead of simply supporting healthy blood vessels, they can participate in communication with nearby cancer cells. And one important signaling molecule involved in this communication is the Wnt5A. And the Wnt5A is a signaling protein, also called legend, and it is released from one cell and binds to receptors located on neighboring cells, including receptors in the Frizzled family. when the Wnt5A binds to these receptors, it activates signaling pathways that influence cell movement, tissue remodeling, and communication between cells. Previous studies suggested that communication between the parasites and the breast cancer cells through the Wnt5A pathway may contribute to tumor progression. And because of those findings, this project focused on the investigating proteins involved in this signaling pathway. Mm-mm. Mhm. Our goal was to determine whether different cell lines express proteins involved in the Wnt signaling pathway. To do this, we use a technique called Western blotting, which allows us to detect whether specific proteins are present in cells. We evaluated 5 pathway proteins: the LRP5, LRP6, the Frizzle3, Frizzle7, and SFRP1. And these proteins were examined across the 3 different cell lines: MCF7, the HeLa cells, and the 293FT cells. One thing my mentor emphasized was that before studying how cells communicate, we first need to know whether the necessary proteins are actually present. So if a receptor isn't expressed by a cell, that the cell can't receive the Wnt5A signal. And that's why this stuff is important in establishing a baseline for the future experiments. And so these images are shown on the slide are examples of Western blot results from Zain and Hilda's project. And the Western blot proteins are first extracted from cells and separated according to their molecular weight.
Where were you living on January 4th, 2019?
Come on, don't mess up.
Working to
Move back to your
yourself.
December to December 1st, Christmas. Right, December 1st around Christmas.
Everyone is muted. That's us. Okay, thank you. Go ahead.
The proteins are then transferred onto a membrane and exposed to antibodies that specifically recognize the protein of interest. If the protein is present, a visible band appears on the membrane, and the location of the band tells us whether it matches the expected molecular weight, while the intensity of the band gives an idea of the relative amount of protein present. And comparing these bands across the different cell lines helps determine which cells express each receptor and which models may be most appropriate for future studies involving the Wnt5A signaling. So rather than proving how the pathway functions, this experiment provides the foundation by identifying which proteins are present before moving on to like the more advanced experiments. And then, so this project demonstrated that breast cancer progression is influenced not only by cancer cells themselves, but also by communication with surrounding cells in the tumor microenvironment. Parasites appear to be one of those important neighboring cells, and Wnt5A signaling may play a role in that communication. By examining the expression of these pathways proteins across multiple cell lines, we establish important baseline information that will help guide future studies. So moving forward, continue to optimize Western blot, improving detection of certain proteins such as Frizzle7, and developing a co-culture models where parasites and breast cancer cells can be grown together to study their interaction in real time can be future steps to take. So ultimately, a better understanding of these signaling pathways may help identify new therapeutic targets that interfere with tumor progression and improve future breast cancer treatments. Thank you, everybody.
You did an outstanding job.
No questions,
Leia.
please.
And no, stay right there. You did an outstanding job. We have every message. Also, grace while we were having some difficulties, and we know this
Clarifies it.
happen at a big presentation. It can happen elsewhere, but you continue to flow through. So we're so proud of you. Everyone is congratulating you. Again, we'll remind you, please, if you're on the Zoom, please mute. Please, please, please. We're trying to find you all and meet you in the room, but it can take some time. Does anyone have any questions for Talaya? If not, I have one, but I want to give y'all the opportunity. Come on, scholars. Part of being a scholar is thinking about what you would ask. Some questions. Anything you want to? What's yours?
How does this benefit in pharmacy? Because
And I'm gonna ask you the question.
that was your question.
No, but I'm gonna ask you to
Just
answer the
talking.
question you posed. How does this benefit you in pharmacy? How do you think it could benefit you?
Well, this summer I was studying pharmacokinetics to get ahead for next semester. So in pharmacokinetics, they have pharmacogenomics, where you test different genes to see if the medication will work for certain individuals.
Yes.
And like some will have different interaction if they have a gene like the wild type and all that. So being able to see the research side of it and how they like implanted.
Yeah.
That was brightening, you know.
I think 100%. And also, while we're looking to see if there's questions online or in the audience, I think, were you surprised that when we think about cancer, we think about tumor cells, but so many cancers have other cells that interact. Were you surprised to learn about how important the microenvironment was?
I was, because I didn't know it was that deep.
Exactly. And so I think for you as a budding pharmacist, if you think about when you have targeted medications that may target a pathway, a gene, something inside of the tumor cell, there are other cells around that may still impede the ability for
and
that.
have effects on the person.
Exactly, to work optimally. So I think as you think about that as a pharmacist, thinking that just like we heard with the myeloid cells, sometimes we need to learn how to target that microenvironment as opposed to just the tumor cells, right? And that's very much aligned with pharmacy also. Any other questions?
No, that was all.
Not from you. We have a question online.
How was doing this research helped sharpen your analytical skills?
My analytical skills, huh?
Yes.
It sharpened it very much because they taught me a different way to think and look at things and how to question it. Because it's all about how you question and come up with things on your own.
100%. That's the biggest part of being a researcher is questioning things. And when you have a question that is not answered, often deciding that you may want to design a well-designed experiment to answer it, right? Okay, amazing job. Thank you. Are you proud of yourself?
Yeah.
Good. Okay, we're gonna see if we could. JC, are you on?
Yes.
Okay, we're gonna see if we can, we think we may have troubleshooted so you can present on Zoom and I'll advance your slides. So we're just gonna try it. Okay, we'll stop share for a second, guys. Thank you. We are. No, I'm gonna share. We're gonna share. Yes. So I just want to move to here the slides. We are gonna share. And I'm gonna. We just get here. Maybe we can be right now.
Well, it's I mostly have
Oops, sorry. Okay, let's test your audio, JC, and see if it'll work.
Okay, are you guys able to hear me now?
We are, yay. And can everyone hear on Zoom? We're good? All right, perfect. All right, without further ado, we have JC Tojo, who's an undergraduate majoring in biomedical sciences, and she worked with Dr. Erin Thrift on epidemiology and population research, and specifically looking at liver cancer and disparate outcomes in African Americans. And she wants to be an anesthesiologist for now. And soon she'll want to be an oncologist. Yeah. Okay, I'm going to advance your slides for you. So give me just a second. Travis, my pointer. Travis. My pointer is. All right, JC, take it away.
All right. Hello, everybody. My name is JC Tojo, and today I'll be presenting my research called Changing Patterns in Hepatocellular Carcinoma in the United States, mainly focused on the trends across age, sex, and race/ethnicity. I completed this project through Texas Southern and Baylor College of Medicine, and I was fortunate enough to work with Dr. Erin Thrift. So a little introduction on this is hepatocellular carcinoma, or also known as HCC, is the most common type of primary liver cancer. It is a major public health concern because it is often diagnosed at a later stage and can have more poor outcomes. Although recent data suggests that HCC incidence rates may have peaked and started to decline, these trends may not have be the same across all populations. Rates may differ based on age, sex, and race or ethnicity, and understanding these differences can help us identify higher risk groups and guide prevention efforts for those higher risks. The hypothesis that I have come up with is that HCC incidence would be highest among older adults and males, would differ across racial and ethnic groups, and would show a recent decline after increasing for several years. As for the methods for this research, to examine these trends, we used hepatocellular carcinoma incidence data from the Surveillance Epidemiology and End Results, also known as SIR or SEER database. We analyzed data collected from the 2000 all the way to 2023. Incidence rates were reported as cases per 100,000 people. Participants were then divided into two age groups, which were 20 to 49, and then 50 years and older. We then compared incidence rates based on sex and race or ethnicity and examined trends over time to identify increases, peaks, declines, and differences between populations. For the results regarding the age trends, looking at the first age, HCC incidence was much higher among adults aged 50 and older than they were for 20 to 49. As for the sex trends, when we compared the males and females, males consistently had a higher HCC incidence rate in both age groups. Although incidence remained lower overall among adults ages 20 to 49, males still had a higher rate than female did. Among adults aged 50 and older, the difference between males and females was much larger throughout the study period. Lastly, for the results for the race and ethnicity trends, when we were examining the race and ethnicity, HCC incidence differed across racial and ethnic groups in both age categories. Rates were much higher among adults aged 50 and older than among younger adults. Non-Hispanic American Indian or Alaskan Native adults and Hispanic adults had some of the highest incidence rates, particularly in the older age group. To conclude, HCC incidence was highest among adults aged 50 and older males and had a consistently higher rate than females, and racial and ethnic disparities remained throughout the study period. A major strength of this study was the use of the SEER data spanning from the 2000 through 2023. However, an important limitation is the individual risk factor were not available. Overall, these findings support the need for targeted prevention strategies and early detection efforts among population at higher risk. I would like to acknowledge the P20 CURED Scholar programs, everybody at CSU, as well as Baylor College of Medicine, as well as Jessica Molina, my research coordinator mentor that I did most of the work with, as well as our PI, Aaron Thrift.
Yay, amazing job. All right, can y'all still hear us? Okay, amazing job. That was outstanding. Folks are giving you praise in the comments. Do any of the scholars have any questions first? No questions? Okay, what you got?
Can you hear me?
Yes, you can hear us, right, JC?
In regards to, like the different ethnicities in the younger age group, where you see higher incidence of liver cancer or no?
Such a good question. Did you hear the question okay?
Can you repeat it one more time for me, please?
Related to, in the younger age group, do you see differences in incidence based on ethnicity?
Yes, it was higher with the non-Hispanic American Indian or Alaskan Native and Hispanic adults throughout all age groups.
Wonderful. Anyone have any questions online? I'll ask one in the meantime. So this is, congratulations. This is really exciting work, and it's cool that you got to use a database that captures all of this epidemiologic data. And I thought it was also impressive that you pointed out some of the shortcomings of it is that you don't necessarily have their individual risk factors. With what hepatocellular carcinoma and knowing that the incidence is higher in Alaska Natives or Hispanics, even early on, what sorts of, did you learn about any risk factors and what sorts of educational interventions you could?
No, we did not. We're currently, as of right now, this summer, we started going into clinics to receive saliva samples to test out the actual risk factors to see if there's a difference in DNA regarding the Harris Health population. Okay. So that is still in the works.
Wonderful. But what about lifestyle risk factors? Can you think of a lifestyle risk factor that contributes to?
It would be about like having hepatitis B or C or fatty liver disease.
Exactly. And maybe alcohol, right? So
yes, smoking, drinking, yes. Because those are all questions that we also do ask when we're, yes.
And since those are established risk factors and you've identified this earlier incidence in some populations, certainly you could envision doing education specifically on that and specifically on prevention, right, at an earlier age.
Yes, ma'am.
Okay, wonderful. All right, great job. Any online questions? All right, give another round of applause for JC. That was wonderful, JC. We appreciate you.
Thank you.
Okay. All right, next we have Robin Lee. Yay, Robin. And Robin is a health administration major, which is an outstanding focus. And she was interested in hands-on practical work, interested in gaining real-world experience that allows her to actively engage. And career goals is to work in a laboratory setting, examine and analyze different specimens, and building a career that combines her interest in healthcare with hands-on scientific work. So thank you, Robin, and I will give you this pointer. Forward back.
Hello, everyone. My name is Robin Lee. I had the opportunity to work with Ms. Jessica Stevens in the Suzanne Fuquay Breast Cancer Lab. And this summer, we were researching targeting replication stress response defects in ESR1 mutant metastatic breast cancer. So a little bit of an introduction. What is estrogen receptor positive breast cancer? Estrogen receptor positive breast cancer is a subtype where the cancer cells have receptors that bind to the hormone estrogen, which then in turn fuels their growth. It accounts for about 80% of breast cancers and is treated using endocrine therapy to block estrogen activity and lower its levels. A little background on the metastatic breast cancer, or MBC, is driven by specific genetic mutations that can dictate how cancer cells grow and responds to the treatment. By understanding these mutations, it is critical because it opens the door to highly specific targeted therapies that can be used in addition to the standard endocrine therapy. A background on these ESR1 mutations in breast cancer. An ESR1 mutation is an acquired change in the gene that encodes the estrogen receptor cells. It's most commonly seen in MBC. The mutations can cause the estrogen receptor to remain constantly switched on, making the cancer cells grow independently without estrogen and allowing them to resist these inhibitors. Okay, for our hypothesis for our experiment was the combination of imlunestrant and talazoparib can reduce the estrogen-related genes, regulated genes, as well as proliferation in ESR1 mutant breast cancer versus standard endocrine therapy alone. So a little background on the three main types of endocrine therapies. We have aromatase inhibitors, SERMs, which are selective estrogen receptor modulators, and SERDs, which are selective estrogen receptor degraders. Aromatase inhibitors are drugs that block estrogen production. Aromatase is the enzyme that converts these androgens into estrogen, and by inhibiting aromatase, much less estrogen is produced, and with less estrogen available, fewer estrogen receptors become activated. SERMs, which are in the middle, they bind directly to the estrogen receptor. They occupy the receptor where estrogen would normally bind. The receptor is still present, but it cannot properly activate gene transcription. So the estrogen receptor remains inside the cell, reaches the nucleus, but DNA activation is blocked without destroying the receptor. And lastly, for SERDs, they directly bind to the estrogen receptor, and they change the shape and then mark it for destruction. After degradation, which is down there, you can see that the receptor is gone, and estrogen has nothing else to bind to, which means gene transcription cannot occur. In specification to our project, we were using the next generation oral SERD, imlunestrant. Imlunestrant blocks estrogen by signaling degrading the estrogen receptor, reducing growth and proliferation of ER-positive MCF7 breast cancer cells. Our targeted therapy here is PARP inhibitor, protein that.
And again, she's still.
Go ahead.
PARP is a protein that aids in repair of single-strand DNA breaks by recruiting DNA repair proteins. PARP inhibitors such as talazoparib block the PARP enzyme from repairing damaged DNA. By preventing cancer cells from fixing their DNA, these drugs can cause the cells to accumulate fatal damage and eventually die. So one of our methods, or a couple of methods that we used, was cell culture. We cultured MCF7 breast cancer cells derived from the tumor of a 69-year-old breast cancer patient. These cancer cells can be continuously grown and passaged for use in downstream assays. We also use the Western blot. A Western blot is to determine the protein levels in tissue lysates. Proteins are separated by size, transferred onto a solid membrane, and then targeted antibodies are used to identify the exact protein that we're looking for. So for our methods, we have the proliferation assay. The proliferation assay, the cells were plated in a 96 well plate, treated with our single and combo agents, and then imaged on the IncuSite to determine the cell proliferation response to our SERD and our PARP inhibitor of interest. Our scratch assay, we do not have any data for our scratch assay, but our scratch assay is a laboratory test that's used to study cell migration and tissue regeneration by creating a scratch and a cell monolayer and observing how the cells migrate to eventually fill the gap. So for our results, for our Western blot, you can see we have our MCF7 wild type cells and we have our MCF7 DG cells. Our control lanes, and we treated with 50 nanomolars of imlunestrant and 50 nanomolars of tala. You can see we have also the 2 lanes of the 100 nanomolars of each, and then we have our combo lanes. At the top, we have our proliferation marker, which was cyclin A2, our estrogen regulated genes, PR and CMYC, and our SNEL, which is our cell migration. And then at the bottom, our GAP-PH, which is our loading control. You can see in the combo lane at the very, very end, it looks pretty clear there. That means there's no protein detected there, which means that in turn, our combo of imlunestrant and talazoparib work to remove the protein. So here's our results from our proliferation assay. You can see the red line is our control or untreated. And you see at the bottom, we have our different combos and singles of imlunestrant and talazoparib. We treated both on day 2 and day 5 of our cells. We retreated with the same concentration of our drug. And you can see the confluency of the control continues to go up as our treated cells continue to lay flat at the bottom. In the D538G mutant cell agent, talazoparib and the combination treatment, they most effectively suppress proliferation. The combination of imlunestrant and talazoparib effectively reduce protein expression of estrogen-related genes and the markers of proliferation and cell migration. And here are my acknowledgements. I just want to thank my awesome mentors. I enjoyed working with them so much. And I wouldn't trade them for anything. They taught me so much about breast cancer, and they helped me so much understand research and how things work in the lab. And I want to thank P20 for giving me the opportunity to have this experiment and have this experience this summer, because I did truly grow this summer.
Yay. Wonderful job, Robin. And I see your team is on the Zoom supporting you. I saw Dr. Fuqua earlier. I see Amanda, and I think Autumn and Jessica were on or are on. So thank you so much. That was an outstanding presentation. You did a great job of simplifying things. Does anyone have questions? We have one in the room.
So we were both in the breast center together. We just have different labs. We use really similar methods. What would you say was the hardest method to learn and like the most challenging one to, I guess, grasp, and the hardest to actually read the results and all of that after you finish them?
I would definitely say the Western blot. The Western blot it's a lot. It's very time consuming, and a lot of the times it does not work, and you have to do it over and over and over again. And the results, I mean, at first they just look like dots on a paper, so it's kind of hard to understand what it is and what it's telling you. But my mentors did great teaching me how to read a Western blot and identify exactly what it's telling you to do.
Wonderful.
I have one question. Robin, you knocked it out of the park. This is Suzanne. Can you hear me okay?
Yes.
Okay, fantastic. So how does it feel to know that you are contributing to a trial that we're going to do at MD Anderson and Baylor your little part, the results you showed in that Western blot, really that is a knockout of the park too, because you blocked many of the genes that cause these cancers to metastasize. How does it feel to feel like you're contributing?
It actually feels amazing. Coming in, I didn't expect our results to really mean anything or contribute to anything. But once we've seen our results and seen the combination effectively reduced everything, it definitely feels pretty good to know that my results.
Fantastic.
Good, feel good. Outstanding.
Fantastic.
So much, Suzanne. Okay, we have one more question, I think, from Trisha.
Well, it's not exactly a question, but I just wanted to say that about what you said in the Western blot, that I can completely agree with them because our lab did that and it's just conducting it.
Yeah. People who've been doing research for 30 years can all agree that the Western blot is a very finicky and very challenging task. And
It's like one of like the most meticulous parts of the lab.
Exactly. All right. Thank you so much. And thank you for supporting who joined. Thank you. Outstanding. Don't forget your laptop. All right. And next we have Madison Ray Hall.
Here she is. She's at home.
Okay. Now mute yourself. We'll allow that. We'll allow it. So Madison Ray is a junior at TSU, and her research interests include cancer, epidemiology, genetics, and medicine. And she wants to be an anesthesiologist for cancer patients. I added that last part.
Okay.
All right, go ahead.
Okay, good morning.
Oh, here you go.
everyone.
You can advance.
It's all right. Thank you so much. Okay, good morning, everyone. My name is Madison Ray Hall. I'm a biomedical science major. I had the amazing opportunity to work with Autumn Hawkins, and in the PQA lab, my project is called Investigating the Switch-SNP Complex and Targeted Therapy for ESR1 mutant breast cancer. So, what is ER-positive breast cancer? Estrogen receptor positive breast cancer is the most common type of breast cancer and metastatic disease. Changes to the ESR1 gene are a significant factor in treatment resistance. This is also the focus of the breast cancer. This is also the focus breast cancer subtype in the PQA lab. And ER-positive breast cancer can progress to metastatic breast cancer. It refers to a cancer that has broken away from the original tumor in the breast and spread to other parts of the body. About 20 to 30% of women will recur with metastatic breast cancer. We use endocrine therapy to fight this, but this also causes resistance. ESR1 mutations are the leading cause of endocrine therapy resistance, and in ER-positive metastatic breast cancer affecting up to 60% of patients. We use SERDs like camizestrant to effectively target the ESR1 mutations. However, the effect can be short-lived and resistance often arrives. So, endocrine therapies. We have AIs, which are aromatase inhibitors. They lower estrogen levels and reduce recurrence. SERMs, selective estrogen receptor modulators, attach to estrogen receptors and block real estrogen from binding. And SERDs, which is what we use in this experiment, are selective estrogen receptor degraders. They completely destroy the receptor, and that's what we call. So the mutations emerge after endocrine therapy and metastatic breast cancer because of the resistance to treatment. They're ligand independent, constitutively active, and increase endocrine therapy resistance. So what are D538Gs? They're specific amino acid substitution in the ESR1 gene that can make ER-positive breast cancer patients resistant to treatment. The letters D and G are shortened names for amino acids, and 5A3 refers to the position on the protein chain where the change occurred. The original D is transcribed for aspartic acid, but with the change, it is swapped for glycine. And then Y537S is most common in ligand domain, and it also causes uncontrolled cell growth. This is the same concept as our D538Gs, except it's just a different amino acid. There's tyrosine swapped for serine, and it acts like a switch that gets permanently stuck, making the estrogen receptor active without needing actual estrogen. It can allow cancer cells to grow and multiply even when the estrogen is low. So this figure at the bottom is a gene. It has the N-terminal domain, the DNA binding domain, which is where the DNA binds, the hinge, and it moves like this, and it allows cells
in and out of the nucleosome. And then we also have the ligand binding domain. You can see right there, that is where the mutations actually occur. So one of the methods that we use is cell culture. Okay, cell culture is the process of growing cells in a controlled environment. It allows us to study cell behavior, disease, and drug toxicity. The cell lines we studied in this experiment were D538Gs and MCF7 wild type cells. MCF7 wild type cell were derived from a 69-year-old woman suffering from breast adenocarcinoma, and is named after the Michigan Cancer Foundation and most studied human breast cancer cell line in the world. MCF7 cells are primarily used as an in vitro model to study breast cancer biology. Due to the number of variants, it has helped advance development of chemotherapeutic drugs and understanding drug resistance. Another method that we used were Western blots. But before we do a Western blot, we also use a BSA assay to quantify our proteins. Then we can use our Western blot to visualize specific proteins in the sample. It utilizes 3 elements to accomplish this. They're separated by size, transferred to a solid, and then they're used by marking target protein by primary and secondary antibodies. Then those antibodies, the unbound antibody is washed off, leaving only the bound antibody to the protein of interest. Then the thickness of the band from the imager corresponds to how much protein is present. So our drug is AU-15-330. It's a selective protein degrader that targets the switch SNP complex and its ATPase subunit SMARCA4. The targeted drugs combined with endocrine therapy have been developed to improve the therapeutic efficacy of ER-positive breast cancer, and the combination therapy approach has been demonstrated to be superior to single agents in overall clinical evaluation. This complex at the bottom is the switch SNP complex. AU-15-330 is a PROTAC, which means that it is targeted medicine that forces the cell's natural waste disposal system to destroy specific proteins. The switch SNP complex cycles through being in an open and closed state to allow nucleosomes to pass through. SMARCA4, which is circled in red, it acts as a battery for this complex, and it gives off energy for the cell. By targeting SMARCA4, you can get rid of the battery that's powering the complex to modulate DNA accessibility. Okay, so we did an incucyte proliferation assay. This measures cell viability. It utilizes phase microscopy channels to measure confluency. We use AU-15-330, camizestrant in single agents and in combination. So our hypothesis is our AU-15-330 and camizestrant synergistic. Synergy is the combined action of 2 or more agents to produce a better outcome than the single agents alone. We use AU in 100 nanomolars, camizestrant in 10, and when we use them in combination with each other, we use half. Yeah. So these are the results from my Western blot. At the top, I have the concentrations, AU-15-30, 100 nanomolars, camizestrant in 10, and our combination 50 and 5 nanomolars. So we'll start off with our control lane. That's just treated with media on both sides. This is the wild type. And our wild type is on the left side and our mutant type is on the right. So we'll start with the concentrations of the drug. AU alone at 100 nanomolars and Cami alone at 10 nanomolars. SMARCA4 degraded AU, as you can see in this second column, it degraded it well, but it doesn't do so well degrading and the others, and ER and c-Myc. So the estrogen receptor is degraded with Cami alone, and in the wild type cell line, the combo treatment AU plus Cami shows better degradation, and in DU, just AU treated alone was able to reduce our ER levels. We also saw a reduction of estrogen regulated protein c-Myc and PR. In the combination treatment, we saw the lowest levels of c-Myc, which is in that red box. This is a suggestion that the combination does better at blocking the ER regulated pathways than single agents alone. Okay. These are the results from my incucyte proliferation assay. The machine takes a picture every 4 hours and compares it to an original start image. Our red line is our control treated with media. And then we also have our single agents and combination treatments. The desired outcome for our data points is to stay low. So we can see the lowest and most consistent points on this assay come from our combination treatments. Our best combination treatment being AU 100 nanomolars and chemizestrant 10 nanomolars. Next, we have our combination AU 25 nanomolars and chemizestrant 2.5 nanomolars. And then we had an increase on day 5, but that was our treatment day. But it's still consistent with our third combination, which is AU 50 nanomolars and chemizestrant 5. While some of the single agents do still do a good job with keeping our confluency low, meaning that there's not enough cells growing over this number of days, the treatment does do better at it, and it would be more efficacious for the patient. So in summary, chemizestrant and AU show clear synergy, achieving consistent protein knockdown across both wild type and mutant cells, unlike single agents, which only affect one type. Our NQ-Site assay shows that all 3 combination treatments show a stronger decrease in cell confluency. Our Western blot showed that combination treatments successfully reduced proteins in both mutant and wild type cell lines, whereas single agents only worked on one or the other. And synergy was shown by combining the 2 treatments to overcome the selective limitations seen in single agent therapies. And these are my acknowledgements. I want to say thank you so much to everyone in the Fuquay lab. My mentors, Autumn and Jessica, were really helpful to me in understanding. And I overall just enjoyed them. I really made friends. And I want to thank you to the P20.
Yay! That was an outstanding presentation. Does anyone have questions? I see your mentors.
Yeah, I'm gonna say one thing. Fantastic, Maddie. Fantastic. You did such a good job. I'm so proud of you. You know, you told me something a couple of weeks ago. I think it was after you were doing a Western blot and how it felt to do that on your own, that you conquered it. Can you tell everybody a little bit about that? Because it made my heart sing when you told me.
Okay, so as y'all could have heard everybody earlier, doing a Western blot is one of the most tedious things that you can ever do in the lab. And then you do it and it still just won't turn out right just because it doesn't want to work. So just to finally conquer it and to finally get results, it's like, wow, like my results actually matter. I'm actually doing something that counts. So yeah.
100%, and we are so proud of you.
Thank you.
Wonderful. Okay, we have a question from within the room.
So if you could go if you could go back like 1 or 2 slides. Yes, right here. So I saw that the combination, you had said that the 25 milliliters of the AU plus the 2.5 was the second leading that decreased the overall concentration. So I was trying to figure out if you guys ever got to investigate why that was versus the 50 plus the chemizestrant in the middle of the 100, if that makes sense.
Are you asking like why the combination treatments were?
Or I think she's asking that often we are primed to think that if you have higher doses of drugs in combination, that it'll automatically be better. Is that what you found, or did you find that a medium dose had just as much effect? Or
a little bit more to clarify the question was because that's kind of what I was asking, because we're normally primed to think that, and as a result, you would think that the second combination treatment that had the 50 nanometers plus the 5 would have produced better results. However, you said that I believe it was the 25, not the 50, was the second lead.
So I think as you think about a complex question like this, one is are we interpreting your results appropriately? Was it that the medium dose was not as effective as the 50 and 5? That's first.
Okay. No, I think the medium dose was still pretty effective. It also is just depending on the treatment days. Like when we treat the cells, obviously sometimes the pictures can go a little bit wonky. I don't think it really.
Yeah, and sometimes what can happen is that you see on your graph that you may see a difference in affected at a certain day, but later on, you may see that difference be smaller, and it may not be what we call statistically significant, or it may not be clinically significant. Is that so? What was your, if you look at these combinations, what would you say would be the doses that you would choose to go forward?
I would say that keeps our confluency down the most is the 100 nanomolar concentration, obviously, and then our what's this? That's 22.5.
Yeah.
That
So let me
was-
ask you this: if you said, okay, these are the doses we want to go forward, are there reasons why, despite the fact that in this assay that is in the lab, that higher dose seemed better? Can you think of reasons why you might choose to go with an intermediate or a lower dose when you're treating either a mouse or you're treating patients?
Yeah. So typically you want to go with the lower doses which is why when we try to do our combination treatments, we did it in halves, because you want to be efficacious for your patients. Like you want low drug toxicity. That's like you're treating it.
There you go.
Yeah, you nailed it there, Maddie. Exactly right.
Nailed it, the toxicity. So that's something that we're always, thinking, oh, we got to go big, but you also have to balance that toxicity, which is sometimes you'll see people too. So that was an outstanding response. Any questions online? All right, thank you. Okay, team Fuqua, y'all have represented. And thank you for joining us. All right. That was outstanding. Everyone has been outstanding thus far. Okay, we have Martinera and Ariana. And Martinera and Ariana worked in the same experience on the same project. So they look like they've coordinated their outfits today. So I'm gonna let them present together. Martinera is a grad student in biomedical sciences, and she wants to be a neonatologist or perhaps a pediatrician. I still think there's hope. I can convince her to become a pediatric oncologist. And she got to work on Smith-Magenis syndrome with Dr. Elsie and her group, which we paired them specifically because this could be something that can affect even newborns. And then Ariana is a senior studying biomedical sciences, has a focus on building research and laboratory science skills, and has some experience in the past with microbiology and genetics and virology and pharmaceutical experiments, and was excited to grow her analytical skills. And I think they'll show us in their presentations how they were able to achieve that. I'm confident of that. All right, take it away.
Good morning, everyone. My name is Martina Henry, and alongside me is Ariana Freeman, and we are presenting our research project on.
So you advance the. Oops. You have the point. Perfect.
Associations between BMI and flu-related behaviors in individuals with Smith-Magenis syndrome. This work was completed through our mentor, Dr. Elsie, and our bench mentor, Ms. Teresa. Our study explores whether body mass index is associated with flu-related behaviors among children and adolescents with Smith-Magenis syndrome, also known as SMS. So SMS is a rare genetic neurodevelopment disorder that affects approximately 1 in every 15 to 25,000 births. It caused either by a deletion in chromosome 17p11.2, P11.2, or by a pathogenic variant in RAI1 gene. Although these genetic disorders are different, individuals with SMS often experience developmental delays, intellectual disabilities, sleep disturbances, and behavioral challenges. One of the most significant concerns involve food-related behaviors. These behaviors can include excessive appetite, food-seeking behaviors, and difficult recognizing fullness. Because of these challenges, many individuals with SMS have a greater risk to obesity, and that negatively affects their quality of life.
This leads to our investigation of whether BMI is connected to these food-related behaviors. So our research question was, does BMI percentile relate to food-related behaviors in individuals aged 2 to 20 years old with Smith-Magenis syndrome? Based on our previous observation, the food-seeking behaviors and weight challenges in SMS, we hypothesized that individuals with higher BMI values would also have higher scores of food-related problems questionnaire, which is known as FRPQ. In other words, we expected that increased weight status will be associated with more severe related food behavior problems. For our methods to address our research question, we analyzed data from individuals diagnosed with SMS who were between 2 to 20 years old, parents or caregivers completed a food-related problem questionnaire, which looks at eating and food-related behaviors. We also used height and weight measurements selected at the time of the questionnaire to complete our calculation with BMI. For younger patients, BMI percentiles and Z-scores were used because this measures account for age and sex difference in growth. Then we analyzed whether the point to determine whether BMI percentile was associated with any of our FRPQ scores and subdomains. So food-related problem questionnaire, which is FRPQ. FRPQ is a caregiver report assessment tool used to measure food-related behaviors in individuals with intellectual disabilities. These questionnaires consist of 19 items completed by a patient or caregiver. It is designed to be appropriate for both verbal and nonverbal individuals, allowing researchers to evaluate eating behaviors across diverse populations. The FRPQ measures three major areas. First, it's preoccupation with food, which looks at how often an individual thinks or talks about food. Second is impaired satiety, which assesses difficulty to recognize fullness or control food intake. Third was composite negative behaviors, which includes behaviors such as taking or storing food, eating non-food items, and displaying inappropriate response to related to food. Caregivers rate this frequency of the behaviors on a 7-point scale from never to always. The scores are then combined to provide a domain-specific and overall measure of food-related problems. High scores indicate greater severity of food-related behavior challenges. This questionnaire is the primary tool we use in this study to examine relationship between BMI and food-related behaviors for individuals with SMS.
Okay, guys, so we're going to take a look at some of the data that our questionnaire gathered from our patients. So we're looking at the BMI percentile ranges for females ages 2 through 20. So at the bottom here, on our x-axis, we have the participants' age in months, and then we have their BMI, and this is plotted along the CDC recommended chart for individuals aged 2 to 20, and then is separated by sex for male and females. So on our female chart here, you can kind of see a little bit in the beginning that within the children, I guess at this younger age, they are within their normal ranges of their BMI, and then as they get older, you have some who are over the 95th percentile. So the normal range on these BMI percentile charts are within 5 to 85% typically, and then weight status normally is determined by where you are along this percentile line. So the weight status categories are underweight, normal weight, overweight, and obesity. So as we said, lots of people with SMS normally are on the obese side because they have the food-related problems. So our BMI chart purpose was to show growth over time. Y'all went to the doctor and they say, oh, you know, kid needs to lose a little weight, maybe they need to gain a little weight. You know, they show over time, okay, how are they growing? How are, things changing, are they tall enough? Are they short enough? What may be going on if they're a little bit heavier? Or what if they're super, super thin? And so these things are typically used to just chart growth over time. And so as we take a look at our male participants, again, the normal range for a normal weight, I guess, would be between 5 and 85% on the percentile graph. And so you have a few outliers who are on 5%, but as you can see, they're at younger ages. Some are even at older ages and are on the 5% line. And then, of course, you see those who are above the 95 percentile. And so we wanted to take a look at the FRPQ, the food-related problems questionnaire, and we wanted to see the average scores and get an idea of where the majority of male and females were. So we had 73 participants who were at the ages of 2 to 20. And so as we can see on here, that mostly females scored just slightly higher than males in our data that we had. And then as we look at these subdomain categories that kind of make up the composite negative behaviors, females still score slightly higher, except for inappropriate responses for food. Males did score slightly higher on average. And so for our results, we wanted to evaluate the relationship between BMI and the total FRPQ score. And so typically whenever we have this graph, we're looking at the trend line to see how far or how close the participants come across the trend line. So as we can see, it's pretty scattered out. It has a random distribution of people who have lower scores, lower BMIs. There are higher scores with higher BMI percentiles. There are a lot actually of participants who had higher BMI percentiles, but as you can see, there isn't really as much correlation between FRPQ score and the BMI percentiles. So our results found that the BMI percentile was not a significant predictor of any FRPQ subdomain or total scores. Our p-values were all above 0.05 in any of the subdomains. So we can conclude from there that there was not really any correlation between the BMI percentiles and the FRPQ score. And some of that can contribute to caregivers and what they do to mitigate the food-related behaviors, because a lot of the participants typically are children. Their parents, their caregivers are saying, okay, you can't eat this, you can't eat that, you know what I'm saying, and are managing these types of things so that over time they can learn to deal with, okay, now I feel full, I won't, get upset because I can't have any more food and things like that. And so in conclusion, BMI percentiles, again, were not a major driver of food-related issues or food-related behaviors. Some possible explanations also could be on why we didn't see a trend was the sample size. Our sample size was kind of small. Age range, 2 to 20 is a very huge gap, and younger children before the age of 6 grow significantly quicker in comparison to after the age of 6. And so age range definitely was a specification that needed to be delved into a little bit deeper. Again, like I mentioned before, some of the issues that could influence our data would be certain behaviors that are managed by the caregivers. And so, as well as other interventions, medications, a lot of these patients with SMS are on different types of medications for different types of things, including their developmental disorders. And a lot of developmental disorder medication or they just, they have weight gain that come with it too. That could be also a reason why, some of these patients had higher BMI percentiles. And overall, our research helps contribute key information to understanding SMS and improving quality of life, but not only the SMS individuals, but the caregivers. They have a hard time dealing with SMS participants or patients because they have a lot of other different types of negative behaviors as well. And this research fills a critical gap by examining whether BMI percentile predicts food-related behaviors, and it offers preliminary data to guide future longitudinal and mechanistic studies. And so we would like to give our acknowledgments to our lab mentor and our bench mentor, Dr. Elsie and Ms. Teresa, and of course our P20 cohorts and scholars for helping us out and really getting us to be able to experience all we can at Baylor.
Yay. Excellent, excellent. Any questions from or online or in the room? Okay, I'll start us off. So a quick comment and then a question. So for you all, you got to do a project that included both information that you gleaned that was reported, right, from patients or from caregivers, but also actual objective data looking at BMI, et cetera. And how was that for you? How was it kind of looking at both, because patient reported data and teasing out even trends from surveys can be very challenging.
Yeah.
And then you often have a hypothesis, right? That if you have a higher BMI, then it's going to be this, and then often your hypothesis is misproved.
Right.
So how was that? And I'll let both of y'all kind of respond.
It was difficult to say the least. We had more respondents. It was, there are people who report like height and weight. There are some people who didn't report height and weight. There are some people who had higher FRPQ scores or was missing a section. So it really is determined upon how the caregiver answers, what they answer if they've completed the FRPQ, and then as well as making sure we're pulling data. Majority of the participants, they were also participants. They're all over the world participants. These are not localized.
It's a rare
US.
disease.
Yeah,
right?
so sometimes reporting could be in like centimeters, sometimes it was in kilograms. Like, so it's definitely like having to go in and really match up the data and try to
clean the data.
Yeah,
right? The data cleaning aspect.
Yeah. So that was the hardest, as well as creating the graphs on Excel.
Okay.
Yeah, Excel is not my friend, but we was powering through,
Yes. Okay, what do you think? Anything to add to that?
Just like she said, it just depends on if the caregivers, how they respond is really a major factor. Sometimes when you're dealing with a child, it's your attention's on the child. So trying to do everything else. It's kind of like
the surveys take time, right?
Yeah, and they do, especially, ask many questions there were in the survey, and as well as how detailed you are and not detailed. And especially with Excel, I had no experience with Excel. Trying to figure that out.
Excel. And I think we have one online. I can't see the top of it, but Brittany, the one that says what's the biggest gap between what the research shows and how care is currently delivered. Can you see that one? Okay. So I think it's related to just when the interventions that are currently done for SMS. And if there was any information that you gleaned from this, especially the kind of how y'all thought that BMI would potentially be a factor. You talked about other medications that they're on. You talked about how many of these patients have developmental delays and how challenging that can be. So is there anything from the data that you receive from these, caregivers or patients and what you learned that could be a signal of something to focus on in the future to perhaps enhance care delivery?
Well, what was brought to my attention were how they were, when trying to care for them, they started doing research on semaglutides.
Yeah.
So I don't know if it helped with them, but I feel like that would be a major factor in them, especially since it's self-injected instead of taken orally, because it's orally, it's not going to do anything. But they were looking at it was on a paper that we had to do. They were focusing on semaglutides, so that could actually help.
And one more question from online that I want y'all to think about, that it says, do you think if you have more objective data, you would have more accurate data? This is constant controversy. Patient and care data can be more subjective, and is one better than the other? People often will, or are they just as important? So think about that, because we have to move on in the essence of time, but there's often a bias that objective data is more accurate, but you gain so much from subjective data. And so I think the combination of both. So I want y'all to think about that. And we'll send the questions to y'all so you can respond directly to the people that's a good exercise to do, that ask that. Thank you so much for that question. All right. Outstanding. All right, we have Michaela Ojubele, and I'm gonna give you the pointer. Get set up. And this is the forward, this is the backward, and Michaela is a junior at TSU. A senior now at TSU. Her career goals are based in neuroscience, and she is thinking that she wants to become a clinician or a surgeon. And we have clinicians and surgeons who work in cancer care. So we're excited. And I met Michaela after doing a lecture at TSU, and she chased us down to submit her application. So good job being a go-getter. All right, Michaela.
So over the summer, my project was based in 293T transfection expression and CAR T cells. And I worked under Mohammed Abu-Aja with Rawa Gabro. And so what is a CAR T cell? Pretty much CAR T cell therapy is a breakthrough immunotherapy method consisting of T cells extracted from a donor and are genetically modified in the lab to express chimeric antigen receptors. And what chimeric antigen receptors are lab engineered proteins that allow the T cells to recognize and destroy specific cancer cells. And these T cells or CAR cells are comprised of the antigen binding receptor and the co-stimulatory domain. So what the antigen binding domain is an antibody derived from a single chain variable fragment, and it binds to a specific protein on the surface of the tumor. And then the co-stimulatory domain activates the T cell upon bonding and aids in proliferation. So for this experiment, we used the co-stimulatory domains CD28 and 41BB. And then the overall objective of my lab is to improve the persistence of CAR T cells against group 3 medulloblastoma tumor models for optimal neuro-oncological immunotherapy. And then our hypothesis was that retroviral transduction is the most effective method in manufacturing CAR T cell production. So our first method was the retroviral transfection, and where we have the cargo plasmid, packaging plasmid, and then the envelope plasmid. So the cargo plasmid's objective is engineered to carry the specific gene of interest to the T cell. Sorry. And then the packaging plasmid PECTAM is used to provide the proteins necessary to assemble the viral vectors. And then we also have the envelope plasmid. And then to carry all these plasmids to T cell lines, we use GeoJuice, which is sorry. You're good. Sorry. You're good. You're doing great. It's used to maximize DNA delivery and minimize cytotoxicity in the cells. So after these cells were gathered and the plasmids were put into the cells, we use OKT3 and CD28 antibodies to select for the T cells, and then we use the cytokines IL-7 and IL-15 to help support the growth. And then together they form the small T cells into T cell blasts, making them receptive to the transduction that we'll do in the next step, which is the retroviral transduction. In this, the 293T supernames were spun onto retronectin plates. And retronectin plates are like pretty much like sticky particles that we put on the bottom of the plate to have the viral particles stick to the bottom. And then we use the anti-PRTG CAR, and PRTG is a cell surface marker that's targeted by the T cells. And it's like specific to group 3 medulloblastomas. And the retrovirus entered the T cells and integrated into the host DNA. This allowed the T cells to express the CAR protein on its surface, so it can target the PRTG expressing cells. And then lastly, the CARs were stained with Lexfluor 647 antibodies that ran through a flow cytometer. And the gating strategy used first selected the single lab lymphocytes before quantifying our CAR positivity and expression density. And then our results, like, sure, okay. So in donor A was like our first run through the flow cytometer just to make sure the proliferating rate of the T cells were efficient. And so and then this was whenever we had our two specific donors. So as we can see, the PRTG expression on, oh, sorry, one more time. And then the bottom is the control where there's no CAR cells, there's no PRTG, it's just the proteins. So the PRTG expression on the small cell lines is confirmed and consistent. Our OG 4-1BB leads in raw positivity, consistently yielding the largest transduction rate. And then the BCM constructs perform reliably high with both BCM CD28 and BCM 4-1BB demonstrating a robust expression, validating that the modified BCM backbone works efficiently for gene transfer. And then our conclusion. So we were able to successfully engineer primary human T cells with high surface CAR expression after the OKT3 and CD28 blast transformation. There was a robust retroviral integration that was shown across both 4-1BBs and CD28 costimulatory domains, showing the platform's versatility. Flow cytometric profiling confirms strong PRTG surface antigen expression on small tumor cell lines, providing a verified target population. And overall, combining blast stage T cell activation with vector-next-gen inoculation shows to be a reliable high yield manufacturing pipeline for CAR T cell generation for medulloblastoma. And our long-term goal is to establish a solid foundation for upcoming in vitro cytotoxicity, because whenever it comes to the CD28 cell line, it tends to be a more intense, short-lived attack to the tumor line, as opposed to the 4-1BB, which is its main like objective is to be persistent. Right. So whenever it comes to the short-lived intense attacks, it tends to trigger cytotoxicity in the brain, and that's something that we're trying to work on to minimize it, get rid of. But yeah, that's one objective, and then we're also trying to do in vitro tumor clearance assays, because right now CAR T cell therapy is mainly used for leukemia and like blood and bone cancers. So we're trying to like spread it out to like lung and like during medulloblastoma, and yeah.
Wonderful.
Thank you for giving me this amazing opportunity to be able to research under these amazing mentors of mine. I really appreciate Rawa. She stepped up whenever Muhammad was away at business and things, and she was a really good mentor as well. So yeah.
Wonderful, wonderful, wonderful. So outstanding job. Do we have any questions in here? I'm a CAR T cell researcher, and I know how hard it is to find the ideal CAR T cell. And I know that going through trying to find out which of these co-stimulatory, the 4-1B, the 28 zeta, they both have their good things about them and their bad things about them, and thinking about how you would modify and identify kind of the ideal CAR to go into a human takes a lot of work. So had you even heard about CAR T cells before you joined this lab?
Honestly, I've heard the name, but like what they do.
I'm impressed that you
have
heard
they
that.
are absolutely not. Like it took me a good like week or two to fully understand.
I'm sure.
What therapy is.
And tell us, as you know, CAR T are most advanced in blood cancers, and we have some early phase trials for brain tumors where we put them directly into the ventricle or where we put them through the IV. Tell us some of the challenges that you envision when we think about giving brain tumors and giving CAR T cells for brain tumors.
Honestly, my main concern in the future of CAR T cell therapy for brain cancers is that the brain is such a fragile and crucial vital organ. And so it's very easy for something to trip up and it can trigger an immune response, which
is expected, right?
which leads to further autoimmune diseases.
Yeah,
as well as the cancer. So
Yeah.
that's-
Exactly. Okay, outstanding job. Any other questions? Very impressive. You learned this in such a short time span. Great job, Vicky. All right, that was outstanding. Thank you, thank you. All right, next we have Sahara Gorkani. All right. And here is your pointer. This will advance you forward and this backwards. Got it? All right.
Hello, everyone. My name is Sahra Gorhafani. I'm first year student at pharmaceutical science at PSU. And I had the opportunity to work with Dr. Antonio Musso this summer. And their lab focus on RNA and RNA structures. I'm just gonna introduce a little bit about RNA. Most of you are familiar with DNA and RNA molecules. They are macromolecules made of small building blocks called nucleotides. DNA molecules carry over genes. Cells use the instruction in these genes to make proteins. But first, they need to convert this information into molecule called RNA, and specifically messenger RNA or mRNA. Through the process called translation. So the process that we use the DNA molecule to make a protein called gene expression. And that this flow of information is called central dogma. But cells do not produce a fixed amount of protein, and they need to carefully control the amount of protein they're producing. At different times, different amount of protein are produced, and it's depends on what cell needs. So, for example, if cells start to produce a lot of growth factor protein, what happens? It's resulting in uncontrolled cell growth and cancer. So, cell needs to carefully control protein production. One of the ways that cell control this protein production is after DNA to mRNA. And this is called post-transcriptional post-transcriptional regulation. So one of the ways that cells can control or regulate mRNA is using regulatory proteins. For example, there's a protein called familial proteins. These proteins can recognize a specific unique sequence on the mRNA molecules, bond to this sequence, and make RNA to be degraded. As you see the example, and an important region involved this regulation is called UTR, or untranslated region. But there is another important layer to this regulation. RNA is made as a single-stranded linear molecule, but it doesn't stay the same fixed structure. It is very dynamic molecule. It can fold back on itself and make different secondary, tertiary structure like stem loop structures. So why does this matter? Imagine that our previous example, comedoproteins. Imagine the sequence that it's recognized and bonded within a structure or hidden in these structures. Does this protein still can bind to this sequence, and RNA can be degraded in the same extent? This connects directly to one of them, Dr. Mustow's major question. How do RNA sequence structure and dynamics works together to regulate RNA function? The lab studies this sequence structure function relationships and develop a computational and chemical methods to measure RNA structure and dynamics in living cells. So how they measure RNA structure, the method they use is called DMS map chemical probing. First cells are treated with a chemical called dimethyl sulfate. This dimethyl sulfate acts like a marker. It's bind to specific nucleotides, that the nucleotides that are accessible, and add a methyl group to this nucleotide. The nucleotides or the region of the RNA that are protected or involved in a structures are not easy to recognize by the dimethyl sulfide, and they are not easily modified by dimethyl sulfate. Therefore, the pattern of DMS modification gives us information about which region or which nucleotide of the RNA are accessible or unpaired. They are not in a structure, structure, and which regions are paired or inaccessible. To find, so the next step is to find these markers, to find these DMS modified nucleotides. We copy RNA into complementary DNA. We do the reverse transcription. In a process, actually the method that the lab uses is a specific method called map reverse transcription, and they develop a specific approach called multi-site map reverse transcription. They use during this step, DMS marks are recorded as mutations in the DNA or cDNA molecule. These mutations act as or recorded as recorded the places that DMS did the modification. So the cDNA is then amplified using two-step PCR. PCR is the stand for polymerase chain reaction. A method uses make many copy, amplify the cDNA, make many copy of DNA. So after do the PCR, the next step is to sequencing. Sequencing shows us the order of the nucleotides and where these mutations are located. After sequencing, computational analysis calculate the mutation rate at each nucleotide. A high mutation rate means the nucleotide was more accessible to DMS and was likely this nucleotide was likely unpaired or unstructured. In contrast, a low mutation rate means that this nucleotide or this specific region wasn't in RNA structure or was paired. And then the next step, this DMS reactivity data is input into a modeling algorithm. The algorithm builds a model of RNA structure based on this data. So for my project, my goal was to measure RNA structure surrounding a selected area that is a pamido protein I mentioned bound to this. We hypothesized that there would be identifiable RNA structure within the 3' UTR region, particularly around a familial response element that could affect RNA stability and function. So what I did, this slide shows the workflow I followed. The extracted RNA was provided to me. Then the first step that I actually did start with map reverse transcription to make the cDNA. After reverse transcription, I performed a two-step PCR using a thermocycler. A thermocycler changed the temperature in a repeated cycle to that the cDNA can be amplified. After PCR, we use two instruments to check the DNA sample that we prepared. That's called our DNA library. Tape station and CURED. The tape station check the size and quality of the DNA fragments. The CURED actually measure the DNA concentration to determine whether we had enough DNA to do the sequencing. And this was where I ran to a challenge. When we measured DNA concentration, it was too low for doing the sequence. The tape station also showed some unwanted product in the sample. So this is the result from tape station. Each lane indicates the one sample. The first two lanes are mine sample, and the other two as a control mentor sample. We can see that the obvious difference here is that we saw strong bands for my mentors that indicates that we have DNA molecule. She was able to produce this DNA molecule successfully, but obviously for me there wasn't any, unfortunately. So I try to, for the rest of my research project, I try to troubleshoot and see where is the problem. So I started with PCR steps. I worked backward through the workflow. First, I performed a PCR2 using a successful PCR product prepared by my mentor. I obtained a reasonable result, which showed that the PCR was working. Next, I performed PCR1 using cDNA prepared by my mentor. Again, I got reasonable result, which showed that the PCR1 was also working. Based on this result, and we narrowed down that the problem is in the RT or MAP reverse transcription step. MAP reverse transcription step is a very delicate procedure, and I have been told that the people that start working and making the DNA library, it's usual and common to run to this challenge. So I repeated the reverse transcription step several times. I checked each part, each step carefully. I corrected small differences in sample handling that could affect the yield. So after repeating the map multiple times, I was finally able to get some results in my methanol, ethanol sample. So I was happy that I got some results. Sorry. In conclusion, the main challenge in this project was the MAP reverse transcription step. MAP reverse is a very sensitive and technically demanding procedures. And small differences in sample handling can affect the amount of cDNA produced. So after troubleshooting the procedure and using more consistent and careful sample handling, I obtained an improved result. This shows that the workflow could be improved by carefully controlling each step. Because of the limited time, I wasn't able to complete sequence and directly test the hypothesis. The next step is to complete the workflow for all samples and computational analysis and determine whether identify RNA structures within the UTR region can affect RNA stability and function. So I want to say thank you, P20 program, Dr. Rain, Dr. Shea, And also a special thank you that my mentor, Dr. Musto, and my bench mentor, Carson Bush, and other lab teams. Thank you.
Outstanding, Sahara. That was great. And I see some of your lab team members on here cheering you on. Does anyone have questions either online or in the room? Or comment? You see Carson is giving you some love. Outstanding. I'll say I think it was very clear from your presentation that you truly understood what you were doing and you understood the complexities and you understood you real-time experience. We often say in my hands, I was able to, and when you're trying to replicate from what someone else has done or trying to expand, and I think that was outstanding. And I think that your understanding of the background and the why and the next steps was very clear, and I applaud you for that. So I would say if you had more time, what would be your immediate next step in your research?
So for sure, I start sequencing and do the computational analysis and see what's going on.
Have you done
structure?
How do you feel about computational analysis?
I like it.
Okay, good.
Yeah.
And it's such a unique skill. It's such an important skill going forward.
Yes, because the method they use, they developed the method called dance.
Yes.
So dance map, and this is unique for their lab, and I really want to learn that, but unfortunately.
Well, we'll see. Maybe there'll be opportunities in the future, but outstanding.
Thank
and people are showing you a lot of love and support online. That was amazing. Thank you so much. I'll take the point in front. And we will have our next Dr. Emily join us to support y'all. She's been in the lab, so we're happy that she was able to join.
We listened to all y'all talks like virtually.
Yeah, she's been on there stalking y'all online.
So
Impressed?
So impressed.
Okay, well, prepare to be more impressed. Brianna Miles is an undergrad majoring in pre-health biology. She's entering her final year at TSU, yay! And also did breast cancer research, and she's interested in cancer biology, molecular oncology, and she wants to become an oncologist. Yeah, a pediatric oncologist. Okay, adults need love too. It's okay. It's okay. All right, here you go. This is the forward and backward.
Good morning, everyone. My name is Brianna Miles. My name is Brianna Miles. At the P20 CURED program, I worked under the lab of Dr. Lee and under the mentorship of Dr. Amy. And it was kind of funny because before I started, I was supposed to be with Dr. Abby, but she went on maternity leave early. So I kind of walked in and went to Dr. Amy, and she was like, But today I'm going to be talking about investigating the role of MAP3K1 in breast cancer. So what is breast cancer? Breast cancer is a genetic alteration, and it occurs when abnormal breast cells grow and divide uncontrollably. Breast cancer is the most diagnosed cancer among women worldwide. 1 in 8 women in the United States will develop breast cancer in their lifetime. Both inherited and acquired genetic mutations contribute to breast cancer development. And by that, it means that you can get this gene from a parent, or you can acquire it over time, which is why it's so important to get those annual visits and annual checkups to make sure everything's okay as women age. MAP3K1 regulates cell growth and is frequently mutated in breast cancer. MAP3K1 is a protein kinase that functions in the MAPK signaling pathway. This pathway regulates cell growth, cell survival, and programmed cell death. MAP3K1 is frequently mutated in luminal A breast cancer, and many of these mutations result in the loss of protein function. Loss of MAP3K1 may disrupt normal cellular signaling and contribute to cancer development. However, its biological role is still not fully understood. This led to our research question. And before I move on, I just wanted to show you guys this diagram. It was honestly the simplest diagram I could find of the MAP3K1 signaling pathway
It just goes through all of the signaling and then of the MAPK pathway with the cell survival, proliferation, migration. To investigate this, we generated MAP3K1 mutant HC11 mouse memory epithelial cells to determine how loss of MAP3K1 affects cell behavior. Hypothesis: MAP3K1 loss alters breast cancer cell behavior. Our research question was, how does MAP3K1 loss affect the behavior of HC11 mouse memory epithelial cells? Hypothesis and specific aim. We hypothesized that MAP3K1 mutations, that introducing MAP3K1 mutations into the HC11 mouse memory epithelial cells will alter its cell behavior. To test this hypothesis, we will generate MAP3K1 knockout HC11 cells and evaluate the effects of MAP3K1 loss on protein expression and cell proliferation. And what I mean by knockout is, it's kind of self-explanatory. With the knockout, we'll take out the protein function of MAP3K1 to see how the cell is affected without this protein. This is kind of a workflow overview. And we first use CRISPR-Cas9 genome editing to generate MAP3K1 knockout cells. CRISPR-Cas9 is a gene editing tool that introduces targeted DNA mutations to study gene functions. This small insertion or deletion will disrupt the gene's coding sequence. We then passage our cells into two 96-well plates, which allowed our cells to grow into single-cell colonies, which then allowed us to passage those single-cell colonies that I guess were the happiest, they were the most crowded, which then allowed us to do the PCR in Sanger sequencing, which confirmed genome editing. We then did our Western blot, which determined whether MAP3K1 protein expression was reduced. And finally, a CCK8 assay measured cell proliferation to evaluate how these mutations affected cell growth. This is just some sequence validation of MAP3K1 editing in mouse memory epithelial cells in HC11. This top one right here is going to be our wild type, and this bottom one is going to be the mutation. Sorry. Each colored peak represents an individual nucleotide base. So as you can see right here, we have our wild type, and then our bases start to go crazy after it's cut. Changes in the nucleotide peaks within these regions confirm that CRISPR successfully edited this gene. These validated clones were then used for protein analysis. This Western blot confirmed reduced MAP3K1 protein expression. This Western blot was used to measure MAP3K1 protein expression after genome editing. Reduced or absent band intensity, like these ones right here, indicates successful MAP3K1 knockout in edited clones. This actin was just a control to confirm equal protein loading. The edited MAP3K1 clones show fainter or absent bands indicating reduced MAP3K1 protein expression after CRISPR editing. These results support the sequencing results and confirm successful protein validation. And then this shows loss of MAP3K1 may alter cell proliferation. This graph is actually preliminary, so we didn't get to this part yet, but my mentor allowed me to use this data just to show you guys something that would happen. The taller bar indicates greater cell proliferation, this one, and then right here is also our wild type. And then the other two are going to be different mutations in the PIK3CA. The MAP3K mutations show different effects depending on the mutation site for these two, and then the findings will be reevaluated using newly validated MAP3K1 mutant HC11 cell lines. And then these findings, because this data was collected before clone validation, the proliferation assay will be repeated using validated MAP3K1 mutant cell lines. And then for our conclusion, successfully generated and validated MAP3K1 mutant HC11 cell lines using CRISPR-Cas9 and Sanger sequencing. We established a reliable model to investigate how MAP3K1 mutations affect breast cancer epithelial cell behavior. And then Western blot and cell proliferation experiments are ongoing to determine how MAP3K1 loss influences protein expression and cell growth. A limitation of this study is that functional validation is still in progress, but this model provides a foundation for understanding how MAP3K1 mutations may contribute to breast cancer development. And then here's my acknowledgements, of course, the P20 CURED scholars, everybody in the program, thank you everyone so much. And then my lab team, it was Dr. Lee's lab, and then my mentor who is Dr. Amy, and then of course all of the lab members for their great support, their valuable conversations. Whenever I needed help finding something, they were right there. Our World Cup talks and all of the fun we had in the summer. Thank you.
Outstanding job. So you got to Western blots and learn about CRISPR and everything.
Yeah, it was a lot.
What was the how exciting was it for you to learn about how these actual assays and techniques that you do in the lab can actually lead to potential new treatments and cures for breast cancer?
Yeah, I think it was really exciting because initially coming in, kind of like what everyone else was saying, I didn't realize how big this was.
Yeah.
I'm actually at a cancer research center. I'm at a medical school.
Yeah.
So going in, I was kind of just like closed-minded, but as I kept going, I was like, oh, I'm doing some.
You're
crazy
contributing
things. Yes, I
to
am.
actual science that could result
Mhm.
in improving outcomes for patients, which
Yes.
is something that is so rare to be able to do.
Because at first I was like, oh, we're just doing an experiment. But
Yeah.
then as we kept going, I was like, oh, we're not just doing an experiment.
Right, it's a part of the bigger plan. And I love to see how when y'all are presenting, it's like the light bulb. We told y'all at the beginning, at first, you're like, you have no idea what's going on. There's so many things that you're learning the techniques. But at the end, it's very clear for everyone who has presented thus far that you understood, okay, this is why I'm doing this. And it often doesn't happen until the end. Research takes a long time, and I'm so impressed at what y'all have been able to do in this time. You saw all the love that people were showing you, and people are cheering you on in the chat. Does anyone else have any questions or comments? Outstanding job. All right. Thank you. Thank you. And right on time, we'll give her a second. We'll give you a second, Trisha. Are you okay to go now, Trisha, or you wanted us to come back to you, give you a second to settle in?
I can go now.
Okay. All right, so next we're gonna have Trisha, who is a graduate student at TSU and is interested in cancer, particularly related to public health, and has a great interest in female-related cancers, and told us about that in her personal statements. And we are excited that she plans to pursue a career in healthcare, hopefully in cancer research.
Well, more specifically, OBG.
Yes, OB/GYN, but those female cancers are taken care of by cancer researchers in collaboration and cancer doctors in collaboration with OB/GYNs. All right, take it away, Trisha. You see the advance on there? Oh, and if you want, I can advance it for you, but this one is forward and this one is backward. You want me to advance it for you?
Okay.
Okay.
So I'm Trisha Bose, and I'm a master's student in biology, and our research is about triple negative breast cancer. So a little background about this. Triple negative breast cancer is a type of breast cancer that lacks the markers for estrogen, progesterone, and the human epidermal growth factor, and it metastasizes aggressively. And the unique part about this cancer is that it's resistant to the standard therapy, which is neoadjuvant chemotherapy. And so far, findings have showed that some tumors would shrink temporarily and then grow back. Some would grow slower or not respond at all. So our hypothesis is more specifically related to the mitochondria, which y'all know would be the powerhouse of the cell. So going back to one of the findings where like a tumor can shrink temporarily and with the chemo administration and then grow back, we believe it's more specifically related to this protein called OXA1L, which is required for mitochondrial functions, and and it's related to a metabolic pathway called oxidative phosphorylation, which is the metabolic pathway by how cells produce their energy source, ATP. So we aim to find out whether this specific pathway is targetable for future treatments. So for our method, we used a cell line called HCC 1806, which was derived from a real cancer patient. And our method included small interfering RNA signaling with targeting the OXO1L protein and to knock it down. And we wanted to see what the impact of OXO1L knockdown would be on various proteins involved in the oxidative phosphorylation, and we could find that out through a Western blot. So here are our results, which I know it looks really messy, but it's gonna make sense in a moment. So as I mentioned before, it's from the patient-derived cell line HCC 1806, where we have a negative control and the 2 small interfering RNAs knocked down switch. The 1 and 9 represents the sequences we used, and each condition was given an untreated vehicle, which is a DMSO, and then we gave 2 individual treatments, which are the common drugs docetaxel and carboplatin, and a combined treatment of both drugs. According to the results, what we can see here is that for the negative control, which is the untreated one, you can see more expression of the OXO1L, even if they're very faint. But with the small interfering RNAs, then all of it are knocked down. So that's why I don't see an expression on these. And then the way it affects and then the next proteins we'll be looking at that we believe might be affected with the OXO1L are COX2, ATP5A, and ATP8. Which ATP5A and COX2 seems to show more expression after knocking down the OXO1L, and then at the bottom are like beta-actin, beta-tubulin, and TOM70. Those were all controls to show that we have equal amounts of the proteins in each of the wells here. And then gamma H2AX is more of a special case. It's also a control, but it also shows which of the drugs, the conditions were treated with the chemo. And finally, our conclusion here, which is kind of to reiterate on the results here. The Western blot showed the OXO1L knockdown. And some of the oxidative phosphorylation subunits have decreased the protein expression. So what we can say from this is that the OXO1L is an essential protein and regulator for that process, as I mentioned. So we can so what we can maybe guess for the future treatments would be that if we knock down the OXO1L protein, then that's gonna, as the name says, impair the function. And then if the function is impaired, that's also going to disrupt the oxidative phosphorylation pathway. And so if we can target oxidative phosphorylation, that may make the TNBC cells more sensitive to the chemo and give better outcomes. And finally, a special thanks to everyone that funded this program, which were our coordinators and our amazing oncologist, Dr. Rain, and then to my lab, and then to our lab team, our PI, Dr. Gloria Echeverria, and then all of our bench mentors over here and their grants.
Okay, outstanding. Okay, do we have any questions from within the room or on our Zoom? And Angel or Angel said, amazing job, Trisha. It was great working with you this summer. Great job. Okay, so you also got to experience Western blotting, and you got to experience how if you could potentially affect a pathway, it might make the triple negative breast cancer cells more sensitive to chemotherapies and treatments. Do you think this is something that could be done in the clinic? For example, you could target this pathway and sensitize these cells to standard chemotherapies?
Well, honestly, it's gonna be hard to answer that now if, but that's actually like what our lab has been trying to find out all along.
Yeah, but it seems promising, right? You see some promising results, okay? Any other questions or comments?
Sure, I can ask a question.
Yeah.
So you use multiple siRNAs to knock down the protein of interest? And when you're moving forward for your next steps, which one of them would you pick to knock down that particular protein? Would you use all of them again, or would you just select one siRNA to move forward with knocking down the protein?
Well, from my understanding of it, it looks like just using one of those sequences might work, but like I could be wrong too.
You would have to test it, right?
Yeah, and I think they both look
Yeah,
like
they
worked,
did.
because sometimes you design an siRNA and it doesn't work at all, but
Right.
a different sequence does. But it looks like yours both worked.
They did, which is very
great.
impressive. All right, well, thank you, Trisha, that was outstanding. Okay. And I think we are last, but certainly not least. Oh, let me move this back on this. We have Amani. All right, so Amani is an undergraduate at TSU, pursuing a Bachelor in Science and Health Administration. We have talked a lot this summer about her career, future career in public health. I believe she will be a public health warrior and be very impactful in trying to reduce the incidence and improve outcomes for cancer. And I had the pleasure of working with Amani along with our community outreach and engagement specialists who are probably taking pictures in the back. And we are so excited to hear what Amani has to say. She was very interested in not only cancer research, but improving outcomes. And so we did a combination of projects for Amani. Do you want me to advance? I can. Okay, if it gets tricky, just let me know. Yep, that's totally. All right.
Hi, everyone.
It's okay. It doesn't have a little lag. There you go.
Hi, everyone. My name is Amani Rowe. I'm a senior at TSU with a major in health administration. I had the honor of working with Dr. Rain, Dr. Ayala, and Dr. Escobar this summer. And my research is over at the mercy of insurance companies, prior authorization, and appeals for cancer therapies. I actually got the name of my project from a CAR-T patient survey that I reviewed. And from what she said, scary, life-saving, expensive. You are at the mercy of insurance companies and other boards for your child's life. A 100% of CAR-T, 100% of patients that are referred to CAR-T cell therapies and do not receive that treatment ultimately end up passing away. Cancer therapies can be life-saving, but patients often can't receive treatment immediately because insurance approval is required. Before patients can receive treatment, insurance companies require prior authorization, and if coverage is denied, patients must go through the appeals process, which can cause delays in care. Right here, I've showed the process of CAR T cells. So it's a genetically modified cell that they insert into the patient's body, and it attacks the specific type of cancer. My goal was to compare appeal policies among the 5 largest insurance companies in Texas. I wanted to identify the similarities and differences in their requirements to make the appeals process easier to understand and help reduce treatment delays when patients and providers are going through this process. And here I'm showing just the CAR-T process. This is before like insurance is even like involved, but the CAR-T process in itself is another thing that is time consuming as well. So I compared the medical necessity criteria, appeals procedures, documentation requirements, and response timelines. I was also able to review guidance from the Texas Department of Insurance. I used this information to create an educational guide for patients and providers. And here, this is the process when they receive treatment. They deal with the insurance denial or if the insurance approves them. And it shows here what they have to go through if they win the appeal and if they lose the appeal. So here, I'm showing my results. These were the top 5 insurance companies I looked at. I looked at their claim denial rate, which ranged from 22% to 19%. A limitation with this is that this is the overall like insurance denial rate. It's not specifically looking at the denial rate for cancer therapies. Another thing I looked at was the appeal filing deadline. It ranged from 60 days to 12 months across all 5 insurances, which when you're dealing with a cancer, that's just way too long. Of course, it's an expedient appeal timeline, which is 72 hours. But of course, like dealing with insurance, they'll say they'll do it in 72 hours, and then they don't do it in 72 hours. And then, of course, it's where to send your appeal form. This one was basically the biggest thing that I was looking at, because when I was looking into the insurances, they all had different appeal forms, but they all were under different names. So when you're a patient looking to find your appeal form, when you're a patient looking for your appeal form, it's hard to find it when all the different insurance companies have it under different names. The only thing that is the same about the appeal form is that it says appeal. And of course, we have it, you can either do it by mail or membership portal. And when it comes to mail, that's another time constraint as well. And then of course, how to track your appeal. You would have to look at your membership portal or call customer service and stuff like that. And of course, another time constraint is the written decision, which also takes 30 to 60 days. In addition to researching like non-medical barriers to novel cancer therapies like CAR T cells, I also had the opportunity to work on a retrospective chart review, looking at the clinical barriers in response to CAR T. I reviewed de-identified patient medical records and helped analyze clinical characteristics and treatment outcomes. This project focused on identifying factors that may influence how patients respond to CAR T therapy, like disease characteristics and other clinical factors. Working on projects allowed me to see the improving patient outcomes required, addressing not only medical aspects of treatment, but barriers that affect access outside of just like medical aspects as well, which strengthened my goal in becoming going into public health. And here is my conclusion. Like I said, insurance policies are not one size fits all. Better insurance navigation has the potential to decrease treatment delays and improve access to care. Insurance barriers continue to affect timely access to life-saving treatment. With educational guides, navigation, we can have the opportunity to improve access to care. So here is just like kind of a snippet of something that I was working on, because of course I'm still working on the resource guide. I actually have a rough draft that I worked on that I want to hand out. Y'all can just take one and pass it.
Here, give us all of
it. But I worked on a rough draft of definitely the at least the insurance, how to deal with the insurance denial for like the patients. And right here for so that the Zoom can see it. This is just what a patient appeal checklist would look like within that guide. And then next to it, I also have the provider appeal checklist. So they both match up, but of course it's going to be different, especially when you are a provider dealing with a patient who's dealing with an insurance denial. And then this is my retrospective chart review as well. I already went over that, but it also goes into because I worked on 2 different projects. This one was a chart review going over the different clinical characteristics and treatment outcomes. And then it also connected to me working with the COE and looking into the insurance related barriers as well. And then here are my acknowledgements. I love my time here at P20. Of course, I had the opportunity to have 3 mentors. I know a lot of people say 3 is a crowd, but the more the merrier. So.
Awesome job, Amani. And you were getting shown lots of love online, and Dr. Bianca Obinion is so proud of you.
That's my mentor.
Okay, I took a picture, I took a screenshot of y'all and just to show that pride. So we are so happy to have you with us, and everyone is cheering you on, and it was an absolute delight to mentor you. Does anyone have questions, comments? I certainly have some. Anybody?
Sorry.
Yeah.
Can you see, like, in a chart review, like, if a patient was denied an appeal?
So
I
that's actually how I started this project. I asked Dr. Rain, I was looking at the chart review and I was just like, how come like a patient when they're dealing with insurance, they get denied initially and then afterwards they get approved.
Yeah.
So that's kind of how this project came about.
So she literally, we were working on her retrospective chart review, looking at clinical characteristics that factor into outcomes of CAR T patients. And we were looking at timelines between when we submitted the insurance and the ultimate denials and when they actually got collected or got the treatment, which is substantial. And she said, I don't understand if they meet the prescribing criteria and they have relapsed refractory difficult to treat cancer and have no other treatment options, how and why could they be denied? And I said, okay, we're gonna switch gears. We're gonna create a new project for you that's specifically on this, which is aligned with your public health interests. And it is a pervasive problem that all cancer doctors recognize. It has been reported on frequently. It is as independent of a predictor and how well you will do as a clinical factor. And what Amani did, and if you look at this brochure, was she was able to, with our community outreach and engagement group, we often do educational interventions where we walk patients and caregivers through what do you do. We also do it for providers, right? Because it takes a lot of time to stay on hold with the insurance company. So our goal is to reduce the time, right? Reduce the time, even if you get a denial, reduce the time in the appeal this every single day. So Amani, because hopefully you'll be able to continue to work with us on this project. What do you see as next steps?
So definitely my next steps is to definitely add more to the appeal guide. Like I was saying, with the different insurance companies, they have different names for their appeals and just how people, like especially dealing with like older people as well, they have a hard time with technology by
It's challenging.
So what I've been doing is I've been looking at each of the different insurances, and I've been going through like a step-by-step process of how they could go in and look for the appeal form.
Amazing. Okay, we'll start with Dr. Bianca, your biggest fan, who has a question for you. Go ahead. You can unmute and tell us.
Okay, Amani first, I'm so proud of you. I'm coming off a night shift, so my emotions are all over the place, but I could really cry because since a high school student, Amani has been having this public health heart. She done a lot of great work around Galveston County. So one thing I want to make just a comment that the reason why I'm smiling from ear to ear is because my older sister is a pharmacist and all she does all day is argue with insurance companies and advocates for her patient. So I know you're interested in public health and medicine, but pharmacy is also a great place to go into too as well. I actually invited her on the call. I don't know, she's at work right now, so I invited her to be on the call to see if she can make a comment about this whole procedure because that's exactly what she's doing. And your journey can take you everywhere. And shout out to the whole team around you for seeing that heart in you because sometimes it has to come from, you have genuine joy and passion for it, and they allowed you to navigate and do this project. So my question is, what is one thing that you'd hope other, let's say, providers, like other healthcare workers, would understand about working with insurance companies?
One thing that can you repeat it for me?
Yeah, like what is one thing that you'd hope that other healthcare providers can understand about working with the insurance companies as far as it comes to getting approvals and authorizations, right? Like, because even me as a resident, I know it's complex, but I don't know how complex it is, right? Like, what's one thing that you've learned that you hope for us to understand?
I would say that like even like especially working with insurance companies, you can say all of the right things and you still can deal with getting a denial. So it's all about like being kind of strategic with everything and having all the documentation that you need to have upfront when dealing with the appeal, because they'll try to go back and say, oh, you don't have this, you don't have that. But if you have it and you're prepared and you have everything that you need, you can rebuttal that and you can work towards getting that approval for your patient. So
Quicker, right? 100%.
just having patience.
Yeah, and
with
having that checklist.
having
you
that
created,
checklist.
right? And knowing that even if you're not gonna address something, you could reach out to your social worker or financial counselor. That checklist, so valuable. Dr. Pounds had a comment, great contribution to this area, Monty. Amazing work. I'm so proud of you. I hope you continue to work and refine the patient checklist and educational material. And I think you may have identified your master's thesis. I strongly am in support of that. And then we had lots of great, and I think I saw a hand earlier.
It was Robert.
Are you still on? Do you have a question? Robert? Did Robert leave us? Do y'all see Robert still on? Okay, if you're unable to unmute, you can put it in the chat, but no question. All right, you were just showing love. All right. Okay, yay, Amani. And I believe that was our last one. It was. Okay, everyone online and all of us in the room who are so proud of y'all. We just got to give the hugest round of applause. I mean, how outstanding to, in such a short period of time, be able to master a lot of the skills. Anyone who's ever does research knows that not even 2 months, because it was really like 6 weeks, is a very short period of time to do any sort of research. And I can't tell you how proud all of us are of you. And on behalf of myself and Dr. Ajawole, who wishes she could be here, Dr. Wong, Brittany, Dr. Jay on, and everyone who supports P20 and everyone on here, y'all did such an outstanding job, and y'all have truly been able to contribute to medical research that can go into patients. And whether it was lab bench research, whether it was clinical research, epidemiology, whether it was patient-reported outcomes and navigating public health, y'all have done an outstanding job, and I promise you this will benefit you in your future. We'll be sending opportunities to submit abstracts for different forums. As a reminder, we'll send instructions on how you get permission from your mentor. You make sure they go over it with you, and that's for any research in the future. Remember, this is a longitudinal program, so one of the best parts about this program is it starts with the summer research experience, but we will match y'all with career development mentors, both from Baylor College of Medicine and Texas Southern University. So you have your kind of mentorship team. And this, will include ongoing relationship with your research mentors, but is more directed towards what are your actual goals? Because many of you are really far away from your ultimate career, not that far away, but you got to get to graduate school, you got to get to public health school, you got to get to pharmacy school. And so a lot of the advice that your career development mentor will help you with are things that are more directed towards that and very general things that we all struggle with. Public speaking, y'all did an outstanding job, test anxiety, imposter syndrome, all the different things, navigating the different pathways and opportunities that will be presented to you. So we intentionally don't match you with your career development mentor until after the summer. Because
So basically what happened with the interview, I was in Galveston.
So we'll be
at
working
the Juneteenth parade.
Stay engaged.
I picked the correct time, second, and I was on a corner and I was backing up to turn around in the middle of the street to get out of the parade traffic. Many people were doing the same maneuver. When I backed up,
okay, so our online folks, we've enjoyed having you so much. We understand if you have to drop off, we're just doing some closing remarks and housekeeping. We are so grateful for each and every one of you for taking the time to join us today, for bearing with us with our technical challenges, and for being so supportive of this work. I know all of you recognize how much work all of you put in. So we'll go ahead and disconnect from the Zoom, and we appreciate y'all. Get some sleep, Dr. Bianca, post call. And we will see y'all later. Bye. Thank you so much. Thank you, thank you, thank you. And if you have questions, y'all didn't get answered, y'all can send them to us, and we'll send them to the mentees, just because it may. There you go. Just leave right on out. Thank you.